Hello everyone and welcome to today's Connect and Learn webinar. The topic is long-acting injectable buprenorphine in the treatment of opioid use disorder. It's great to have you all with us today. Before we get into today's webinar, I would like to acknowledge the traditional custodians of the land where we are presenting from today, the Wurundjeri people of the Kulin Nations. I would also like to pay respect to elders past, present and emerging, and extend this respect to those First Nations people who might be watching this webinar. My name is Phoebe Spry-Bailey. I'm one of the education officers from Turning Point and I will be facilitating today's webinar. This webinar is part of a series of the Connect and Learn webinars. They are designed to support AOD workers throughout regional and metropolitan Victoria to do the great work that you're currently doing. And we also welcome any interstate viewers. These webinars hosted by Turning Point and funded by Victorian Department of Health and Human Services. Just a little bit of housekeeping. We've on the top right-hand corner of your screen, there are some useful tools. So we like to make these webinars as interactive as possible. So first of all, feel welcome to ask questions throughout the presentation, and I'll be collating all those questions and then asking our presenter at the end. You're also able to download some resources for this presentation. So there's a PDF version of the slides, but there's also the draft guidelines that are associated with this presentation, and Vicky, our presenter, will talk more about those. And then just a little reminder at the end that there will be a survey for you to complete. So we really appreciate if you do that so we get feedback, and we welcome any suggestions for future webinars, whether that be topics or speakers. I would like to introduce our presenter, Dr. Vicky Phan. Vicky is a Senior Medical Officer working at the Medically Supervised Injecting Room in Melbourne and a lecturer for the Monash University Master of Addictive Behaviours course. She has experience working across alcohol and other drug and mental health services in both New South Wales and Victoria. She believes in a holistic and person-centred approach when working with people and their families. Her areas of interest include mental health comorbidity, harm minimisation, pharmacotherapy, training and education. So great to have you along today, Vicky, and thank you so much for taking the time out of your busy day to come here.
Thanks, Phoebe. And I'd like to start by saying thank you to everyone online for joining as well. So as Phoebe's mentioned, I have completed my addiction psychiatry training, and I suppose that's the background that's led me to giving this talk today. I recently completed my training through Turning Point, where I was the trial physician on a study looking at the use of Buvidal, a form of long-acting injectable buprenorphine in the treatment of opioid use disorder. And I also currently work at the Medically Supervised Injecting Room, where we offer Buvidal to clients presenting there. So I'm very excited and pleased to be sharing some of the experience and knowledge we've been able to gain so far on this very new treatment. So just to start, a brief overview of what I'll be speaking about in the talk today. There'll be a brief introduction into opioid use disorder or opioid dependence, and I'd just like to briefly go over that because people need to meet that diagnosis to be able to have access to this brand new treatment. Secondly, I do like to go through a brief overview of opioid agonist treatments, looking at the current state of play and where this new treatment fits in. Thirdly, I'll speak to the injectable buprenorphine itself, and more specifically Buvidal and Sublocade, the two brands that are currently in use. And then at the end of the talk, I'll talk about how people can access injectable buprenorphine and then discuss some brief case examples of clients we've had go on to treatment. There'll also be time for questions at the end, and please feel free to send through the questions as I go. So to start off with, looking at opioid use disorder and how people can get diagnosed with this diagnosis. It's also known as opioid dependence. The term opioid use disorder is a DSM-5 term, and essentially this is an important thing to go over because, as I said before, you have to have a diagnosis of this to be able to access such medication through the pharmaceutical benefit scheme. So according to the DSM-5, for people to have a diagnosis of OUD, they essentially have to fill two of the following 11 criteria within a 12-month period. And the 11 criteria are here on this slide, but broadly speaking, they refer to people having cravings for opioids, people using opioids in hazardous situations, people using excessive amounts of opioids, people experiencing withdrawal phenomena when they stop using opioids, people having tolerance phenomena when they're using opioids, people using opioids despite no mental or physical health harms, people giving up activities because of their opioid use, for example, social, occupational, recreational ones, people having to spend excessive amounts of time using, recovering, obtaining drugs, and then also people finding difficulties controlling or managing their use, people giving up obligations because of their opioid use, and then damage to personal relationships as an outcome of their opioid dependence. The exception to this is that for people to have a diagnosis of opioid use disorder, the two criteria of tolerance and withdrawal are not enough if people are receiving prescription opioids under a suitable medical care regime. Essentially, if people are using prescription opioids and that's how they get opioid use dependence, there has to be some other criteria or some sort of aberrancy feature. So going into opioid use disorder in Australia and New Zealand as a brief background, in 2014 the number of people in Australia and New Zealand living with opioid use disorder was over 66,000 and over 13,000 respectively. It does seem to have a high prevalence in males. The number of males with opioid dependence seems to be 2.5 times the rate of that of females. And the cost of the burden of opioid dependence is quite significant as well. So in Australia it was 42 billion or 2.5% of GDP, and in New Zealand our neighbours across the ditch were spending 5 billion. And this is data from the Royal Australian New Zealand College of Psychiatrists study. Looking at the Global Burden of Disease study, the disability weightings for opioid dependence, just comparing it to other significant mental illness, it sits quite high. It's above what we see for severe alcohol use disorder and just slightly below what we see for severe major depressive disorders. And then going now into the state of play that's been present for opioid agonist treatments for people with opioid dependence so far, and why this talk is interesting. Up until last year, all we could offer our patients were predominantly methadone and Suboxone. So looking at this slide here, at the top of the slide you can see methadone liquids, which either come as aspirin, methadone liquid or biodone, aspirin being the kind of yellowy coloured liquid there and biodone being the red one you see. And then at the bottom half of the slide we've had buprenorphine, which has typically come in this sublingual strip film formulation, which is the little orange strip you see there that goes under the tongue, if not the dissolvable, crushable sublingual tablets that kind of look like orange hexagons in the corner. Doing a side-by-side comparison of methadone and buprenorphine, which have been the main treatments. So first looking at methadone, just a brief overview of how it works. So methadone's a full agonist at the opioid mu receptor. For people to prescribe methadone, they have to do MATOD training, which is medically assisted treatment of dependence training in Victoria. That's a day training course run through the College of GPs. Methadone's got a long half-life of 8 to 59 hours, which makes it suitable as a treatment for opioid use disorder because people can just dose once a day. There's slow titration to get to effective dose, so typically people would start at a 20 or 30 milligram dose and the top dose would be around 100 milligrams, and increment increases can be as slow as 5 milligrams every 4 days or so. It's got abuse potential, so we have to be careful with how many takeaways we give, and in Victoria the maximum is 4 takeaways a week generally speaking. And to reduce the risk of diversion, when pharmacies dispense methadone, they have to dilute it with water up to a 200 ml volume, and that's to prevent spitbacks and to make sure that people swallow it properly. So now speaking to buprenorphine. So until last year, the only forms of buprenorphine we had available were Suboxone and the Subutex tablets, which were the strip and the orange hexagon tablet you saw in the earlier slide. And now we have Buvidal, which is an injectable form of buprenorphine. Briefly comparing how buprenorphine works. So it's a partial agonist at that opioid mu receptor, but it's got what we call high affinity, so it will bind to that receptor very well. GPs can prescribe up to 6 patients without any specific training, so access to buprenorphine has been easier in that respect. It's also got a long half-life of 24 to 60 hours, and it has less time to get to an appropriate dose. So whereas with methadone we were talking about slow increments over a long period of time to get to a good dose, with buprenorphine people usually sit between an 8 to a 32 milligram dose, and people can get up to 16 milligrams within 3 days or so. It's got a lower risk of overdose because it has what we call a ceiling effect. So that partial agonist effect means that it has less risk of causing things like respiratory suppression and sedation. And it's harder to abuse because if you look at Suboxone there, that picture, it says it's got buprenorphine and naloxone in it, and naloxone being Narcan. That's in a 4-to-1 ratio. The reason why naloxone's in there is because it's there as a safety mechanism to prevent people trying to dissolve the strip and inject it. If it's taken sublingually, the naloxone isn't actually bioavailable, so it doesn't have an effect if people consume it the way it's meant to be consumed. And it's taken as is, so there's no extra preparation work for dispensing pharmacies. So why do we use these opioid agonist pharmacotherapies? Because they're gold standard evidence-based treatments for people with opioid use disorder. There's 2 main indications for us using such treatments. Firstly, we can sometimes use them as brief treatment when people are in opioid withdrawal and detox units, and in those instances we might use them for a couple of days at lower doses just to manage the opioid withdrawal symptoms. But the mainstay is using it for prolonged pharmacotherapy for opioid use disorder, and people can be on treatment for months or years even. What we know about opioid agonist therapies is that they're effective, they're safe, and they're also cost effective. So they save up to $7 for every $1 invested for drug and alcohol treatment. And depending on which literature you look at, those numbers can sometimes be even higher. From a health perspective, the main advantages is that opioid agonist pharmacotherapies can reduce both mortality and morbidity. So by mortality, I mean deaths, including overdose deaths, and by morbidity, I mean other adverse health outcomes, including blood-borne viruses. We also know that opioid agonist treatments also have other benefits to individuals and the wider community. So they reduce rates of crime and they reduce burden on the criminal justice system. They assist people to have healthier, happier families and social relationships, and they also help people return to work, which is really important as well. So the limitations of opioid agonist treatment so far, the issues of treatments to date and why having new novel treatments in this sector are so important is because there are issues getting people in treatment and retaining in treatment so far. I've divided those issues into 5 main categories. So speaking first to structural barriers, often people who experience opioid use disorder are homeless, or they might be participating in activities that put them at risk of incarceration, which can make getting people into treatment and retaining people in treatment quite difficult. There are healthcare system barriers, so we know that there are limited dispensing points and pharmacies that will dispense Suboxone and methadone in the community, particularly in rural and regional areas, and that can really be a barrier for people with opioid use disorder accessing treatments. We know that at pharmacies where they dispense methadone and Suboxone, there can be limitations on space and capacity of pharmacy to take on patients, so sometimes people might live close to a pharmacy that dispenses but still not be able to get on their books. And we know that going to pharmacies for dispensing is inconvenient for people. It means they have to travel to pharmacies. It means that they have to adapt their work schedules to be able to get to pharmacies, and it really becomes sometimes an imposition on their lifestyle. There are also provider barriers. So as I stated earlier, for people to prescribe methadone, they have to do additional training. So not all doctors are able to prescribe all opioid agonist treatments. And having access to trained providers can be an issue for clients as well, particularly, again, if they're living in regional or rural settings. There are pharmacotherapy barriers, so there are limitations to the treatments themselves. With methadone and buprenorphine in the form of Suboxone and Subutex, people have had to have daily supervised dosing, particularly at the start of treatment, and that can be a negative for clients looking at care. And then we also have patient barriers. So there's still a bit of stigma about being on opioid agonist treatments. It costs money. So typically to go to a pharmacy and have methadone or Suboxone dispensed, people can pay up to $5 a day or so to access treatment. And often in our patient demographic of people experiencing opioid use disorder, there's often concurrent mental health illnesses or physical illnesses or stresses in their life, which might affect their ability to engage with care, continue having care and receiving their medication daily as well. Which brings us to long-acting buprenorphine, which is very exciting and a new form of treatment that we can offer people with opioid use disorder. And this is a real game changer because methadone's been around since about the 1970s in Australia. Suboxone, or the sublingual form, sublingual form of buprenorphine came into play in the 1990s, and just last year in September, the Pharmaceutical Benefits Scheme approved Buvidal long-acting buprenorphine. So that's been the first innovation that we've had in this field for over 15 years. So looking at Buvidal and Sublocade, and I'll speak to Sublocade in a second, they're the two forms of long-acting injectable buprenorphine that are used currently. So they're both long-acting or extended release forms of buprenorphine. Buvidal is produced by a Swedish company called Camurus. Sublocade is produced by Indivior, which is the company that produces Suboxone. And Buvidal is available as a weekly or a monthly injection, whereas Sublocade is only available as a monthly injection. Buvidal is currently the only form of injectable buprenorphine under the PBS in Australia, and what that means is that's the only one that we can currently prescribe. But I will speak to Sublocade during this talk because it's currently available through treatment studies in Australia, which means it's only available to study participants in those studies at the moment. But we may be seeing Sublocade roll out in the next few years, so I've just included that in this talk for completeness. Looking at the studies we have on Buvidal and Sublocade so far, so there's been quite a few international trials on their safety and efficacy. Buvidal, there have been 7 international multi-site trials published, including a phase 3 trial of more than 400 patients. Sublocade, there's been 2 clinical studies of up to 840 patients. As I said earlier, so Buvidal was approved by the Therapeutic Goods Administration in 2018, and then it was PBS listed in September last year. Sublocade has also had TGA approval as of July last year, but we're currently awaiting PBAC review for PBS listing for that, so that may still be a while to go. And then doing a side-by-side comparison of these 2 medications, and I'll go through one at a time. So starting with Buvidal, so as you can see in the picture at the top of this slide on the left, Buvidal comes in a pre-filled syringe. It uses this liquid crystal nanotechnology where it goes in as a liquid, very small volume liquid, less than a ml. It's a clear straw-coloured liquid, and then that will react with the natural kind of water solution in the body to form a gel deposit under the skin. The doses are there on that table, so there are 4 weekly doses that are available and 3 monthly doses that are available, and they can be correlated with Suboxone doses. So if someone's on a 2 to 6 milligram daily dose of Suboxone, that's equivalent to an 8 milligram weekly dose of Buvidal. If they're taking 8 to 10 milligrams of Suboxone a day, that is equivalent to 16 milligrams weekly of Buvidal or 64 milligrams monthly of Buvidal. If they're taking 12 to 16 milligrams of Suboxone a day, that can be equivalent to 24 milligrams weekly of Buvidal or 96 milligrams monthly of Buvidal. And finally, if they're on 16 to 24 milligrams of Suboxone a day, that would be considered equivalent to 32 milligrams weekly of Buvidal or 128 milligrams of the monthly Buvidal. The injections are forgiving in the sense that the time points do not have to be strict to 7 days or 4 weeks. So for the weekly injection, there is a plus minus 2 days leeway in recognition of the fact that sometimes it can be quite difficult for people to come exactly 7 days or 28 days after their last injection. So people can have their weekly injection within a 5 to 9 day interval, and people can have the monthly injection, again, plus minus 1 week, either side of 4 weeks since their last monthly injection. The way that we start people on Buvidal, so typically people would be recommended to have 7 days of Suboxone first before they transfer to the Buvidal injection. The advantages of that are we can make sure that there are no hypersensitivity or allergic reactions to buprenorphine before people get a longer term deposit of buprenorphine under the skin. And it can also help assist practitioners to work out what a reasonable dose is for that patient so that we can convert the dose according to that table just above. It goes into a fat pad in the skin, so it goes into subcutaneous tissue, and we're looking at either the buttocks, the thighs, the abdomen or the upper arm, and we rotate sites, so if people have had an injection somewhere, we don't go back there for the next 2 injections. In terms of duration of action, so if people have the monthly injection, you see the peak effect 6 to 10 hours after. If it's the weekly injection, you see the peak effect 24 hours after, up to 24 hours after, so it's got quite rapid onset. And the half-lives are quite long as well. So the weekly injection has a half-life of 3 to 5 days, whereas the monthly injection of Buvidal has a half-life of 19 to 25 days. It takes a while to get to steady state. So steady state is level concentrations of the drug, and that typically is about 4 injections for Buvidal. So that's something to consider. So patients might feel like they want to escalate doses at the start, and it's worth having that conversation that it takes some time for the injection to get to steady state. But if there is a need to increase the dose, for example, if people have just had a monthly injection and they feel that that's adequate 3 weeks in, then people can have top-up weekly Buvidal 8 milligram doses to see if that has more of a desired effect. But it has to have been at least 24 hours since their last injection to access that top-up dose. There is reasonable guidance to say that we can also use Suboxone as top-up for people who are on Buvidal injections too. That's not on this table. And in terms of storage, the injections have to be stored at room temperature below 25 degrees. And then comparing that to Sublocade, which, as I've said before, isn't currently PBS listed but is under study, that uses an H-gel extended release system. The image of the syringe is there, so again a pre-filled syringe. The colour of the liquid can vary from being another light yellow colour to this deep amber colour that you see. And the doses there are 2 doses. So they're monthly doses. There's either a 100 milligram dose or a 300 milligram dose. Sublocade uses a kind of loading system where people will have 2 300 milligrams injections each month for the first 2 months, and then afterwards it's a clinical decision whether they continue on 100 milligrams or 300 milligrams. Generally speaking, if people would be stable on 16 milligrams less of Suboxone, you would consider keeping them on 100 milligrams, whereas if they're relying on over 16 milligrams of Suboxone equivalent a day, then you'd probably consider the 300 milligram injection. If people are using less than 4 milligrams of Suboxone a day, you'd probably consider commencing them on a 100 milligram loading system rather than the 300 milligram. In terms of administration, again, recommendation is that people start on Suboxone for the first 7 days before they move on to the Sublocade injection. And again, it goes into subcutaneous tissues or fat pads, but for Sublocade, they have limited that to the abdominal area only, so below the waist but above the hip bone. The peak effects of Sublocade are again within that first 24 hours post-dose, so quite quick, and the half-life of that injection is 43 to 60 days. It's also forgiving in the sense of the intervals, so people can have the monthly injection as early as 2 days before the time they're due and as late as 4 weeks after they're due. And if people are feeling like the Sublocade dose isn't enough, you can use rescue doses of Suboxone on top. The storage requirements for Sublocade are a little different to Buvidal though, so this one has a cold storage requirement between 2 to 8 degrees. It has to be taken out to room temperature at least 15 minutes before administration, and once you take it out of the fridge, it can be left out of the fridge for up to 7 days, after which it has to be discarded. So looking at the images of the different injections, so these are quite nice diagrams of how they're administered. So the interesting thing to note here is that even though Buvidal is a subcutaneous injection, it's administered at a 90-degree perpendicular angle, which is different to the usual 45-degree angle we would see for subcutaneous injections. The diagram on the top right there, the sites in blue are the subcutaneous areas where we would be rotating injections. And then the images below show that you have to put together the injection. So when you take it out of the box, there's a plunger, which is the stick you can see in the right hand there that needs to be screwed in, and then it's pushed down on. The image on the bottom is a kind of schematic diagram of how the injection goes in. So the liquid buprenorphine is deposited under the skin, and then that will form that kind of gel-like drug compound under the skin, which then sits there and gradually releases over the week or monthly period. And then looking at Sublocade to compare, so again the pre-filled syringe, this one goes in at a 45-degree angle, as you can see, as most subcutaneous injections are. And then the diagram in the middle on the right there shows the kind of donut or abdominal regions in which we can administer that one. So looking at the evidence to date we have on these injections, so Buvidal, there was an active control, randomised control trial that was published in JAMA in 2018. That was a direct comparison of Buvidal versus your usual sublingual buprenorphine. They looked at illicit opioid users entering treatment. It was double-blind, double-dummy, so active like placebo. And they found that Buvidal was at least as good as the sublingual buprenorphine treatment, so it was a non-inferiority analysis. And then looking at those diagrams in the right there, you can see how the two compared in terms of urine test results with self-report as well. Looking at study 499, which is a study of long-term patient safety with Buvidal, there were over 227 patients in over 30 centres across Europe, USA and Australia examined, including 4 sites in Australia with 29 patients. This was an open-label natural condition study of 12 months of treatment, and I think the interesting thing to see from this study, looking at that diagram on the right in the bottom corner, was that 83% found the injectable form of buprenorphine much better than the sublingual buprenorphine that they transferred from. And then that diagram from the right shows that for people who are on sublingual buprenorphine, the number of opioid negative urine drug screens were sustained, and then for people new to treatment on the Buvidal injections, it increased over the course of the study. So looking at the data relevant to Australia, so there's been a few studies to date in Australia on both Buvidal and Sublocade so far, so we do have local data. So study 499, as I said before, had 29 Australian patients. The debut study was a study that I was involved in, so that was a randomised control study looking at Buvidal compared to Suboxone across 6 sites in Australia. There were a little over 100 patients recruited. It was 6 months of treatment, and that's primarily been to look at patient satisfaction, substance use outcomes. Publications are pending for that. And there has been a study in New South Wales called the Unlock study, which is specifically looking at the use of depot buprenorphine Buvidal in the prison system. So that's been led by Adrian Dunlop and is looking at 7 prison sites there. Sublocade, there has been a study this year called the CoLab study, which has been looking at people's reactions to Sublocade, specifically their satisfaction, patient outcomes, treatment costs, and patient and clinician experience. And that started recruitment around May of this year. So this table looks at how we compare doses across the products. So if you look on the very left of the screen, Subutex, which is that tablet form of buprenorphine. Then in the middle you've got Sublocade, and then on the right you've got the weekly and monthly forms of Buvidal. So the interesting thing to see here is that if you look at the bars, the doses of Subutex up to 24 milligrams largely match those of weekly and monthly Buvidal, but Sublocade does have a bit of a rise compared to everything else, which suggests that it might have better pharmacokinetic parameters for people who are on above a 24 milligram dose of buprenorphine usually. So the pros and cons of injectable buprenorphine treatment. So I guess what's interesting and exciting about this new form of treatment is that it's a sustained extended release formulation, which is helpful in that it can help assist steady state delivery. Typically what we see of daily dosing is these daily peaks and troughs in treatment, which people can experience as withdrawal or hanging out right before their dose. The weekly and monthly forms of injectable buprenorphine can help manage that, so there's less daily variation in their drug concentrations and the drug that they receive. These forms of treatment can help address opioid use disorder and opioid-related deaths, mental, physical and social consequences related to that by helping retain people in treatment and offer a new form of treatment. It can improve medication adherence and make treatment less onerous for clients who are looking at treatment. It can help reduce the risk of buprenorphine diversion and IV misuse because these injectable forms are a lot harder to manipulate. It can help reduce unintended pediatric exposure and issues with unsafe storage. So one of the issues with takeaway doses has been making sure that they're safely secured and that people who are vulnerable and opioid naive don't access them. And then it can also help reduce negative perception, stigmas and barriers to treatment that people have experienced so far with traditional treatments like methadone and Suboxone. It is a new form of treatment that might help address disruptions in treatment for people who have difficulties getting to pharmacies daily, difficulties getting to reviews regularly, because we have the option now to give people medication at monthly intervals. It can help free up service resources and offer new models of care, because the dialogue changes if you cut out discussions, for example, around missed doses out of the equation in your ordinary clinical encounter. And I guess the cons, or the things that are uncertain about these treatments, is that they require new procedures for drug storage and administration, because, for example, Sublocade, you require a fridge. And it's still a new treatment, so it's still unclear what the effect is in the long term of these medications on reducing monitoring, attendance, treatment outcomes in the long term as well. So now, speaking to how people can access injectable buprenorphine, so I think the really important thing to say is that it's currently still restricted access. So as part of the conditions for rollout through PBS last year, currently the state of play is that only addiction specialists are able to provide these treatments. Addiction specialists have to have completed the medically assisted treatment of opioid dependence training, and they also have had to complete Buvidal specific training to be able to prescribe. The practitioner has to be working within a service that is able to store the medication as well, either themselves or by the service having a health services permit. And then the usual conditions related to starting this treatment. So first and foremost, these people have to have been suitable for buprenorphine or Suboxone in the first instance. So if people are looking to start this new medication, they have to be on Suboxone first. And the usual process of having a prescriber, having a dispensing pharmacy for that, and having a permit for that are needed. If they do well on Suboxone and they want to move on to the injection, then they need to find that addiction specialist care. That addiction specialist then needs to apply for a permit for the injectable buprenorphine and determine if that patient is a suitable candidate for this injection as well. And then there's a discussion around whether that person might be suitable for a weekly or a monthly dose of that injectable buprenorphine. And then once people commence the injectable buprenorphine, it's continuing treatment. So each patient gets given an alert card after they get dosed with the injection, which says when their last injection was, what dose there was, and gives some emergency contact information in the event they need to go to emergency or need to go to another doctor for care. And then there would be weekly or monthly review, and then discussion around contingency plans for top-up doses if they need between doses as well. The way that the permit system works is, so now with the rollout of SafeScript in Victoria, you can access those permits online. So, for example, if a patient was on the buprenorphine weekly injection, this is what you'd see in the permit section of their SafeScript profile. You would see the drug name there. In the presentation, you'd see it would say depot injection, and it would list the start dose that was applied for. So there are scope for this information to be on SafeScript so that people can look up to see if patients are getting injectable buprenorphine. And then finally going to some case examples of clients who have been started on buprenorphine. So starting with Todd. So Todd was a client who was 35 years old. He was unemployed. He was on the DSP and living in Ministry of Housing accommodation. He had a background of opioid use disorder from heroin use since his teenage years, and then that developed into OxyContin misuse. He was also intermittently using ice on top and cannabis, and he also had a lived experience of schizophrenia and depression. His past medical history was notable for having motor vehicle accidents at both age 9 and age 22. He developed traumatic brain injury from that, and he also had a splenectomy and injuries to his abdomen from the second car accident, as well as injuries to his spine, head, hips and ribs. He then ended up with an acquired brain injury and epilepsy. His schizophrenia and depression were case managed under a community treatment order, and his medications included Tegretol, diazepam, olanzapine, aripiprazole injectable depot, and also Suboxone. So his treatment with Suboxone was quite difficult because he'd previously diverted that. He'd often forget doses of Suboxone because he was forgetful, and he at times could be intoxicated with these other substances and forget to go to the pharmacy. He was still using heroin on top of his Suboxone, and then he had periods of incarceration and interruptions in treatment whenever he went to jail for shoplifting and drug-related offences. There were limits to how many takeaways we could offer him because of the concurrent substance use and unstable mental health issues. So it was really difficult to get this guy to do well with Suboxone treatment. He was missing doses, he had unstable other health issues, and he was willing to start on Buvidal, so we put him on Buvidal. He had a 128 milligram monthly injection, and he did quite well on that. And he went into custody for theft, burglary and fraud, and fortunately at the time that he was incarcerated he had had the injection before, and he came out just in time for his next injection, so he was able to have some stable treatment with this injectable form. And then going into case 2, so Gareth was a 36-year-old unemployed single male on the DSP as well. He had a background of opioid use disorder from heroin use since his late teens, and he also had a lived experience of bipolar affective disorder. He had a past medical history of hepatitis C from his injecting drug use, which was treated. He also had psoriasis. His mental health history was significant for depressive episodes, mostly from the bipolar, and he had last been hospitalised in April of 2018. His regular medications included Epilem, Prestique and hydrocortisone cream for the psoriasis, and he was on Suboxone of 32 milligrams a day. He found it difficult to remain in Suboxone treatment because he continued to use heroin and he was groin injecting with it. He missed the doses when he was using heroin, and the financial cost of dispensing was a real barrier to him accessing treatment. So we put him on Buvidal 128 milligrams monthly, and he entered detox and then a long-term rehab. Whilst in rehab, he returned to us for his monthly injections, and he'd reduce his dose because he wanted to eventually transition off treatment and use the long-term recovery of rehab to tail off the injection. So now I suppose we have time for questions. So if anyone has any questions, please type them through. We've received a couple before this talk as well, and I'd be very interested to hear what people's thoughts are or questions are about this brand new treatment for those of you attending.
Thanks, Vicky. We have got a few questions that have come through. But I might just start with questions because as we actually got lots of questions before the presentation when people were registering. So just for things that maybe haven't been covered in your presentation, someone's written here, what happens if someone requires opioids for an accident during this time? Is there something that can reverse it?
Okay. So the ways in which, for example, we would manage acute pain for people who have long-acting injectable buprenorphine on board is very much the same as we would for people who take Suboxone. So it does pose challenges to pain management because there is a partial acting opioid agonist on board. So usually what we do in the instance of people on buprenorphine is that you could provide additional buprenorphine in the hospital setting, or you could provide opioids which are a bit more potent at the mu receptor and more override the action of the buprenorphine. People get given an alert card to say that they're on this injection, and that's got an information number on it for health practitioners to contact if they have any queries about people receiving analgesia whilst having these treatments, because we understand that it's a totally new form of treatment for people. But essentially it's the same as if people are on other forms of buprenorphine like Suboxone, Subutex. The pain teams in hospitals are quite familiar with processes like using alternative non-opioid treatments like ketamine, for example, for these patients, or adding on non-opioid analgesics or overriding with things like fentanyl. So people can still have access to good pain care even with these treatments. There's not a way of reversing the treatment. There has been one instance where they've removed the buprenorphine in America because somebody had some liver issues. Usually they say if you're going to remove it, it should be within the first 2 weeks. It gets, I suspect, quite difficult to remove after that because it's quite a gel-like consistency and it's just in that fat tissue. But it does wear out over time as well, so it's not a barrier to people getting their pain needs sorted if they're hospitalised.
Thanks. Another question, how to support clients who may still want to inject substances. So what's the impact for them?
Yeah, so I guess like other opioid agonist treatments, this isn't a panacea. It's one part of care. So medication has a role to help manage physical withdrawal symptoms from opioid use disorder. It also has a role in help managing craving, often when we get to those higher doses. But the role of drug and alcohol counselling, the role of mutual aid groups, the role of mental health support, physical health support remains. People might still continue to use heroin or other illicits on top of injecting buprenorphine in the same way that people might continue to use heroin or other illicit opioids on top of methadone or Suboxone treatments. I think when that happens, the question is, first and foremost, what are the reasons for that use? Is the treatment dose effective, or does that need to be reviewed? Is there potentially other supports that can be provided for this patient outside of the injectable buprenorphine treatment? So holistic care is still necessary, and if people are using on top of injectable buprenorphine, that's, I think, a flag that some conversation and clinical review needs to happen.
Thank you. And question around withdrawal. So how would people withdraw from Withdrawal?
So it's got a bit of a tail, this drug. So like I said earlier, it's not that you get to 7 days or 4 weeks after these injections and they cliff face off. There's a downslope of the concentration of the drug. So we still see levels of buprenorphine in the body a couple of weeks after these injections are stopped. If people, I think the two instances in which you'd see people experience withdrawal from these drugs are either if they miss their next due dose or if they're trying to cease treatment. If people miss doses, then I think it's about trying to get them back within those 9-day, 5-week intervals as soon as possible so that they don't start to feel uncomfortable without the medication. And if people are deliberately trying to stop the injection, for example, to wean off treatment, then the most comfortable way to do that would be to gradually wean down the dose as much as possible within those injectable regimes. And then if people are finding it difficult to manage withdrawal symptoms at that tail end of the final doses, there is option to go back to things like Suboxone and Subutex to help manage craving as needed and to whittle down the doses as the patient's able to.
Thanks. Now, someone's asked here about, you mentioned how that at the moment only addiction specialists can prescribe, and they were just wondering if you know when GPs are...
Yeah, so there's been no definite date on that yet. It will be up to the TGA and PBS to decide that. They certainly are recognising that there are a lot of GPs out there, particularly in Victoria, who hold a lot of patients with opioid use disorder, but there are several logistic constraints. GPs would need to be willing to have a drug secure safe for Buvidal and then a lockable fridge in the case of Sublocade in the future. So it will be up to GPs whether they would want to do extra training and would want to store those injections on site to deliver that. And it's kind of up to government organisations to decide when this can be rolled out to GPs. But at this point in time, we don't have a date yet, no.
And would that include nurse practitioners as well?
Yeah. Nurse practitioners working with drug and alcohol specialists can provide it at the moment, but working in isolation, similarly, no, that's not currently available.
Okay. And during this time, there is a question that's come up. Do you, like, it says here, will coronavirus lead to an opening up of availability for clients? I don't know whether you can reply to this one.
So I think that's probably a health service specific question. Like with other health services, there are multiple challenges with coronavirus at the moment. I would refer to your local health service to see what their current scope is in terms of taking on patients if they provide this, and also, I suppose, keep on top of department advice around how this affects things more broadly as well.
Thank you. You okay to answer a few more questions?
Yeah.
We've got a few here. We have got a question here which isn't specifically around Buvidal, but someone's asked here, you were talking about DSM diagnosis of opioid use disorder, and someone's asked what DUDIT score would reflect a DSM diagnosis.
So the DUDIT isn't specifically for opioids, so you can't use that to diagnose opioid use disorder. It's a good screener to detect drug use issues in patients. To make a diagnosis of opioid use disorder, the client really needs to be seeing a doctor and having a thorough assessment to see if they do fit that criteria in the DSM, or alternatively the ICD-10 also has a separate diagnostic clarification system which is quite similar as well.
And then there was a question around implementing it in prisons. You've sort of addressed that it's in trials up in New South Wales.
Yes.
Did you want to add anything else? Or is it...
That'll be a big area to watch because one of the big issues in the prison system has been a reluctance to prescribe and administer buprenorphine there because of the diversion risk. That's caused issues in clients where they have been on Suboxone, for example, and then ended up incarcerated and not being able to access that treatment in jail. Methadone, for the most part, seems to be the mainstay in the jail systems. We are hopeful that depot buprenorphine might offer an alternative in prison, so I'll be very interested to see what the result of the UNLOCK study is. But I think the principle is that as an injectable form, it's harder to divert. It'd be very difficult for people in jail to take the depot out and give it to somebody else. So watch this space. It may be something that we can offer in future if results are promising.
Right. And then one final question, because we know in the alcohol and other drug sector there's a lot of acronyms, and someone's asked, is this the same as XR-BPN extended release?
Yeah, correct. Yes. Yep. So extended release is the same as long acting. So this is if you see people referring to extended release buprenorphine, they are referring to these long acting buprenorphine injections.
Okay. Sorry, there is more. How often are you?
And thank you everyone for sending these questions.
Yes, lots of. Sorry, we're just trying to. How often are you providing top-up dosing? Have you any experience with reducing or increasing dosing interval to manage exposure to withdrawal issues?
Yeah. So the top-ups, going to Buvidal, because that's the one we have available, the top-up dose is an 8 milligram weekly injection, and the monthly injection, the interval to give that is earliest 3 weeks since the last injection and latest 5 weeks since the last injection. So if, for example, if patient X presents on this week, has a monthly injection, then presents next week and says, this dose isn't holding me, I need a little bit more, then they could have a top-up weekly injection provided they're not on the top dose of the monthly injection. And then the week after, if they're week free, they could come back and have another weekly injection until they run into that next due date for their monthly injection. The interesting thing to note is that the top dose of Buvidal for monthly is 128 milligrams, which if you looked at the table earlier goes up to about 24 milligrams. In the debut study there was scope to give 160 milligrams. That's not currently available in Australia though, so in some instances it'll be up to the discretion of the specialist prescribing, but you can sometimes give a little bit higher than the 128 milligrams through 2 injections at the one time. Generally speaking, though, 128 milligrams seems to hold most people, and if people are on a lower dose, like 96 milligrams, do well with those weekly top-ups, then you'd think the next time they're due for that monthly, we may as well increase to the 128. Similarly, if they're getting those top-up doses and you don't really see an effect, then it's a good idea to have that conversation where we tried going on a high dose and that didn't really change the pattern of use or the thinking or the feeling, so we can retain on the 96 milligrams and be confident that maybe it's other things like ancillary social services support that this person needs more.
I feel we could ask Vicky anything about this and she can give a great answer. Thank you so much for spending time to do this. Cost?
Yes, yeah. Great question. So the Buvidal is currently under Section 100, which means that it's paid for by the government, so it comes at no cost to patients. Currently under most health services it's being dispensed and provided free, but if it rolls out into community we might see that there's a dispensing fee associated with pharmacies stocking and providing the medication to practitioners to administer. But at the moment, $0 cost, which is great for patients and has really shifted that barrier when it's come to people with low incomes or New Start allowances who really struggle to get that $5 dispensing fee cost out of their budgets.
And a registered nurse can administer it?
Yes.
Yeah, you don't have to be a nurse practitioner in particular.
So we routinely have nurses in our services administering these injections. They're quite simple to administer. They do recommend a slow push so that they can be a bit more comfortably delivered because it is a bit of a thicker liquid. But the administration is, relatively straightforward because there's no drawing up or anything like that.
Okay, and someone's asking here, is this treatment recommended for shorter periods such as 4 months?
Yep.
And she's giving context around that later on because they have clients coming to residential rehab and come off their Suboxone in approximately a 4-month period. So that must be a condition of their
so treatment. So treatment periods are an individual, I think, doctor-patient discussion. There's no set time frame that's required for the medication, so to speak. Generally speaking, we know that people do better on opioid agonist treatments if they are on treatment for at least a year. We know that remission rates can sometimes sit around 10 to 20%, so people should get as much support as they can. I guess in terms of duration of treatment, I think the take-home point earlier was that steady state takes a while to get to. So if we're talking 4 injections to get to steady state, it could be 4 monthly injections before people get to that really comfortable level in the body. So if 4 months of treatment, you might only just be starting to see how people are going on a dose. So you'd probably recommend that people go a bit longer to really see the full value out of this treatment.
And this really is the final question.
Yep.
Any, if it was injected into the muscle, what would the effects of that be?
So you'd probably get a localised reaction, discomfort, swelling. The most common things we see with the injection is sometimes people get a bit of redness or itchiness or a lump under the skin. The lump is usual because it's a deposit and usually that will just come down over the course of time. The main things that you want to avoid with this injection is not going inadvertently into a vein or an artery because it can form a thrombus because it solidifies when it goes in. So you've got to be really careful with where you're going and make sure you go in a fat pad because of that. The sites that are selected on that diagram are really just to help minimise the risk of it going anywhere else. So I would stick to those sites. A pinch method is recommended so that you don't get muscle. So if you pinch, then you're just capturing skin and that protects the patient and protects you against any adverse outcomes. And if you do experience any difficulties with it or if the patient experiences any difficulties with it, you do the usual process of telling them to seek medical advice as soon as possible.
Well, thank you. Thanks, everyone, for joining us today and all the fantastic questions, and in particular, big thank you to Vicky for coming in and, you know, giving a comprehensive presentation and just answering questions from everywhere.
Yeah.
So thank you so much.
No
It was
problem.
really appreciated, and, you know, it is always exciting when we have a new treatment option for the people that we're working with. So
I might just quickly add, so New South Wales has put out a really comprehensive guideline on the use of long-acting injectable buprenorphine. They speak to both Buvidal and Sublocade. Currently, that's the only state that's put out a guideline. So if you're wanting more information, that's probably the go-to resource. Buvidal has a website, Sublocade has a website, and they both show videos of how the drug is administered if people are wanting to see that. I guess in future local states or other states will probably be putting out guidelines too. So this is still an emerging area. There's still developing resources in the works, but for the moment, if people are looking for more information, I would recommend that New South Wales guideline, which we'll be putting up for download as well.
Yes, so just for those watching it live, if you're watching it on demand, then you'll have to go to the websites directly. So that brings us to the end. So thank you very much. Just a little reminder, if you could complete the survey that Redback will be releasing very soon. And we'll see you at our next webinar in the next month. Okay, thanks.
Thank you.